already when we were talking about looking at some of the cardiac things. You can see how the heart is not extending beyond it. Okay, here it comes right up to the border and ends. Esophagograms also are still done. Just a couple of anatomic things. One is you'll notice that we can see the rugal folds, I call them rugal. You can see the muscular folds well here. The proximal third of the esophagus we have control of. Okay, so we can swallow, and that proximal third, we're initiating the peristalsis. The distal 2/3 is more of a reflex. Okay, so once it's started, it will continue. Okay, it also gets initiated for forceful constriction by expanding it with food. Does that make sense? Okay. All of you are going to have patients who have dysphagia. Dysphagia needs to be assessed. Okay. All of you will have patients who have big osteophytes that displace the tracheal air shadow in the cervical spine, or they might have DISH that has enough thick ossification that does the same, and they have dysphagia. And if they do, then you need to follow it. Okay? So you basically have three options. Option number one is barium swallow. Okay? All right? And what you're looking for is to make sure that there's not a mass, that the only thing that would answer the question as to why they have dysphagia is that it's going over that. There's no other lesion. Okay? There's no other mass or anything like that. And very often,